I'm going to talk about creating the evidence base for addressing the cancer burden in Africa. And in 20 minutes, you can't really do this justice, so I'm going to give you some experiences, some lessons learned that we have had over the past 18 years of doing collaborative research in Africa. And I don't need to repeat, but I will, just that Africa's future cancer burden is substantial. We don't have really good rates or information about what cancer is going to look like. But based on the information that we do have, I think we can reasonably say that in the next 2 decades, the number of people who will die of cancer in Africa will approximately double, and that we can guess that 1.2 million, or at least something in that range, number of Africans will die of cancer in the year 2035. So as has been made very clear from previous presentations, and I'm sure you know, this is a public health crisis. This is something that needs to be addressed. And as Princess Dina and others have said this morning, we just have to do something about this, and we have to work on it. So that's easily said, but what do we do? How do we make that happen? So let me give you a couple of thoughts that I've had based on our work in these areas. So I'm going to sort of think about 3 key components that we need to worry about. The first one being understanding the needs and opportunities that we face when we're going to address these very large public health issues. We need to think about people challenges and people resources and systems that are involved in addressing these problems. And these 3 components hopefully will lead to impactful science, both the basic understanding of what it is that is going on in the African setting, and then taking that knowledge and moving it into change, both prevention, treatment, survivorship, palliative care, science as the generation of knowledge that will allow us to make the kind of impact we need. So I'm going to use an example of work that we've been doing since about the year 2000, so going on 20 years now, in the Men of African Descent and Carcinoma of the Prostate Consortium, known as MADCAP. MADCAP involves about 20 centers across the African diaspora in Africa and North America. I won't go through the whole history of how we got here, but we currently have NIH funding and other funding. We have numerous partners that are all functionally able to do research, to collaborate, to talk to one another. And it's been an incredibly rich and rewarding experience for us to build this. But in the process of building this global team, we've learned a few things. We've had a few experiences, and that's kind of what I'd like to relay to you. So let me start with the key components. What do we need to do to understand the needs and the opportunities? And so just some thoughts about how we want to think about addressing these problems, these very important public health problems of cancer in a place like Africa, where we have numerous challenges but many opportunities. So let me first start by saying that it's possible to address problems in a place like sub-Saharan Africa. And I use the example of malaria. Malaria obviously is one of the key killers, has been one of the key killers of Africans in the past. But over the past decade or so, 2 decades, we've been able to address malaria. We've been able to reduce deaths from malaria on the African continent substantially. So this plot shows some of the data from the World Malaria Report. This is a little old, but I looked it up last night, and it's still accurate, reasonably accurate. In 2000, about 900,000 Africans died of malaria, and by 2017, it was around 400,000. So they've dropped the number of malaria deaths in 17 years by half. And how did they achieve that? Well, they achieved it by addressing some very critical components. So there's been a recognition of the problem by key stakeholders. The public health officials, world health officials, governments have recognized that malaria is a problem. Not that anybody needed to be told that malaria is a problem, but it was raised to the level of critical importance that key stakeholders decided it should be addressed. And as you heard again from Princess Dina this morning, the WHO and the UN and other bodies are now starting to and have made substantial strides in accepting that cancer is a major problem in places like Africa. So we're beginning to get that recognition from important stakeholders that can make things happen. And that doesn't just include the UN. We heard heard a moment ago about CHAI and ACS and IBM Foundation and others who are doing this. So the level of recognition by people that can make a difference is starting to happen, just like it did with malaria a couple decades ago. We also, malaria became addressable because there were evidence-based interventions, bed nets and insecticides and things like that. Those are things that were developed based on evidence and knowledge, and that's what I'll talk about in a second. We need to create knowledge that motivates our ability to address problems in a cost-effective way that is sustainable, as it has been done with malaria. And finally, dedicated funding and resources. The Global Fund came along, among others, that really implemented some of these things. Money, resources were dedicated to the problem. And as a result, malaria deaths have dropped. We've begun to address the malaria problem. It's not finished yet, of course, but we've been able to make an impact. So can we do the same thing in cancer? Well, obviously, I think the answer is yes, but if you look at what's happening with cancer, this is predicted data from GlobalCan. But you can see that in the past, over a couple of years ago, the number of people in Africa who have predicted to have died from cancer exceeded the number of people who died from malaria. So we crossed the line between addressing a malaria problem with some very specific targeted activities, and now we need to do the same thing with cancer so that in the future we won't continue to have this increase. We can start dropping the number of cancer deaths. So how do we do that? How do we think about that? Well, I think there are 2 points that we need to keep in mind. The first one is that why would we want to do this? Why would we in Boston or in London or somewhere else care about reducing cancer deaths in Africa? So one reason is that by doing this research, by generating this knowledge, we're actually going to learn. We're going to create science. We're going to create knowledge that will benefit the whole world. So we've learned in the past, so this is Pliny the Elder, many hundreds of years ago said, semper aliquid novi Africam ad feri. Africa always brings us something new. Pliny was talking about giraffes and tigers, I think, but we have also learned a great deal by studying situations in Africa. Africa has been a hotbed of science in the past, teaching us about Burkitt's lymphoma, combination chemotherapy, Epstein-Barr virus, staging and chemotherapy for hepatocellular carcinoma. These are things that were done in Africa by Africans and taught the world about important problems in cancer. Africa has unique disease etiology and natural history, so in prostate cancer we're able to study aggressive prostate cancer because that's the phenotype we see there. We want to eliminate that as the common phenotype, but it allows us to take a situation, a natural history of disease that we don't see as commonly in the U.S. and study it so that we can bring it back to the U.S. and the rest of the world and understand the aggressive nature of prostate cancer. And this will hopefully allow us to understand disease across the African diaspora. Aggressive prostate cancer is an important problem in African Americans. Can we use knowledge that we've gained in Africa to benefit people here and everywhere else? So by undertaking this work, we can learn and we can benefit the whole world. And I think that we have evidence that that has been the case and can be the case. The second reason that we want to be doing with this work is because we need to create knowledge that will benefit Africa itself, obviously. So Julio Frank, who was the Dean of the School of Public Health here, stated that the creation of knowledge has been central to the advancement of health in the 20th century and is critical for improved global health. So if you think about where we were, where the United States or Europe was in 1900 compared to where we were in health by 2000, an incredible amount of progress was made, and that progress came about because we generated knowledge. We created science, and we created knowledge that was able to have an impact. So knowledge gets translated into appropriate technology, drugs, diagnosis, prevention, etc. It gets internalized by people and empowers them in key domains of life. So you can imagine a lot of examples: smoking, eating habits, safer sex, whatever it might be. It's a social and economic driver and disruptor of patterns in the system that need to be changed. And it's the basis for health policy. So we can guide decision makers who can be convinced of what needs to be done if we have good data to present to them. And so in order for Africa to come out of where they are now and into a better state of being, just like the United States and Europe and other places have done, we have to generate knowledge. And so the ability to generate knowledge really requires what was described before. We need to collaborate, we need to work together, we need to get our feet wet and do work in Africa so that we can achieve these goals. So the two pieces that we need to do that, among very broadly stated, are people. So there's a lot of people challenges when working in Africa. The system has an inadequate workforce, as we're well aware, a lack of academic infrastructure. So there are plenty of very bright, hardworking people, but the academic infrastructure to create research, to do the basic science, to create the knowledge that we need is often missing. And it's difficult to recruit and retain people in these kinds of settings, not because they're not interested or they don't have the capacity, but we don't necessarily have the resources, the colleagues, the mentorship in place in order to achieve the people skills and the people resources that are required. And also when we, particularly working with people in Africa, those of us who are not Africans, but have an interest in seeing Africa progress in terms of its activities, and even within Africans and across African countries, we see that there are interpersonal issues of communication, which is difficult, although, as you saw just a minute ago, it can be done. We can communicate, and we can do it pretty effectively, but we have to work at that. There are cultural and semantic differences within and between countries in and outside of Africa. There are sometimes lack of governance models and lack of trust. These are things that it's not that they don't exist. They have to be built. We have to spend time working at these things in order to make them happen. So in the MADCAP consortium, we've begun to do this by creating some platforms that allow us to have the interpersonal relationships, the communication, and build trust. We've developed, in collaboration with Yuri Quintana, who's here at the Beth Israel, a collaborative learning systems and built on a foundation known as communities of practice. And I don't have time to go into this today, but it's a structure that allows us to think about communities who have a common interest, but to develop knowledge and experiences that they can use to grow professionally and personally, but also then to generate the knowledge. And so there's a structure. Again, not something that you have to reinvent. There are ways, structures, protocols, models that allow us to build impactful communication and networking skills. So on the MADCAP side, we have our learning collaboration platform, which includes an online learning platform, as well as an online collaborative platform. And this is a website, but it's a little bit more than a website. It is not just providing information in a static way. It's actually something living that people go to. They're able to get into the website and do Zoom conference calls and share data and share information. And so this is something that's really quite effective because it allows people to click in and call somebody. Or email them or text them or something like that from a common website that we all use. So there are platforms that have been built that allow us to develop these people interactions. And finally, systems. Systems, as you can imagine, are difficult to generate, but and there are a number of challenges. The first one that we've experienced is that institutional commitment and buy-in is really critical. I guess a lot of these things I'm saying are probably not news to you, but it's really critical that we get the institutions who are supporting this to make substantive commitments to what it is that we're trying to develop. And this, again, is interpersonal communication. It requires that we teach or work with the institutions, be the ministries of health, the universities, hospitals, why our problem is important, why they should care, and how we can help work with them to make these things happen. Infrastructure is often present but siloed. As many of you know, there are a lot of resources in Africa. Where we work, there are genome centers, there are biochemical laboratories, there are basic scientists, there are clinicians doing clinical trials. It's not that these resources don't exist. They may not be as large in number or as well resourced as some others in the United States or Europe. but they're often there. And the key thing is that they are often siloed from the kinds of questions that we need to or want to address. So we need to bring together those existing resources and enhance them through workforce, facilities and equipment, and data management resources, and bring them together, enhance them so that the work that needs to be done can actually get done. I'm always surprised when I go to a new place, or even in the places I've been working, how much infrastructure and how many people are actually there if you look for them properly. As you're well aware, there are many supply chain breaks. These are systematic system problems that need to be addressed so that the supply chains for resources, reagents, et cetera, can be managed, and that includes breaks in treatment and therapeutic agents as well. We often don't have standard operating procedures, protocols, and QA/QC practices that are well documented, for which people have been trained and they've been assessed. These are things that you just heard from Meg O'Brien are being developed systematically for treatment. These same kinds of things need to be developed in all aspects of research and clinical care and prevention, et cetera. And finally, we don't always have realistic success metrics. Clearly, we need to have success metrics so we know, first of all, what we're shooting for when we set out, but second of all, know when we've reached it or when the metric that we've set up is unrealistic and we need to change it. So again, these are things that are fairly obvious, but these are things that come up all the time. And there are actually ways of addressing it. So we've recently written 2 papers in the Journal of Global Oncology this past year that outline how we in the MADCAP world have addressed some of these problems by setting up protocols and processes that address the ethical issues, the regulatory issues around research, fiscal issues, fiscal management, and then logistical things. So the ethical obviously include human subjects, IRB protocols, consents. These are things that need to be in place, and there aren't always templates, essentially, that can be used to build on. There are so many regulatory hurdles in governmental compliance, interinstitutional agreements, et cetera, that need to be developed, and having, again, a protocol that allows people to understand what needs to be done and how it can be done, we and others are putting into place in order to get research going. The fiscal requirements include a lot of issues of compliance, invoicing payments. They're nitty-gritty, day-to-day boring stuff, but it's things that need to happen, and they need to happen accurately, adequately, and in a way that people can work within their existing systems or teach their existing systems how to make it happen. And finally, the logistical, the supply chain questions and the success metrics and things like that all have to be developed. So there are a number of us, not just MADCAP, although we've started to address protocols and processes that work for us, but these things need to be systematized, just like the clinical care models that you just heard about need to be systematized in order to make the endpoint successful. So a couple of lessons learned from the last 20 years of our work. It's really critical that you have a dedicated local PI, somebody who is well-connected and influential, willing to promote to their superiors, to the ministries of health, their bosses, the heads of hospitals or heads of universities, what needs to go on and be effective in that role, but also willing to promote and mentor junior scientists. This is something that, that this local person, it makes all the difference in our mind. And the success stories that I have in developing our network, I can point to the person who made that happen locally. And the places where we haven't been able to have as much success, I can say that that person has been absent. So this is a key thing, and they're out there, and it is possible to find them. It's critical that you have an academic environment that enables research. So again, you have to have substantive institutional buy-in. Sometimes you need to have that institution make sacrifices, make commitments, like giving investigators research time, lightening their clinical load. That's not a trivial thing to do, given the overburden that many people have in their clinical work and in hospitals and medical centers have. But in order for this to happen, it's got to exist. And related to that, in many settings, there aren't academic tracks. There's not a tenure track where research is valued and people can then use their research experience to gain success and be recognized. Those things have to be created. So there have to be ladders and metrics of success that the institution will acknowledge and support. There have to be scalable platforms and processes. Again, all the things that I said in the last slide of protocols, they need to be built and set up, and they need to be scalable. They need to be able to be grown or shrunk depending on the needs. There have to be achievable goals and realistic timelines. Sometimes that's the hardest thing, to know what is realistic and what is achievable. Doing that up front is really important. And finally, regular communication and bidirectional exchanges. Again, the web is great, but FaceTime is critical, and that you need to have these things, and that takes people's dedication to get on a plane and money to pay for it, but those things are critical in order for anything to be a success. So to end, what should we hope to achieve once we make these investments and set up these strategies? Well, we should have improved capacity for research infrastructure. We should have a better trained local workforce on many levels, and improved translational capacity. We should be able to take what we've learned and put it into a public health setting or a clinical setting so it has impact. And the impact that we should have, and I think this has been said a couple of times already, the work that should be done in Africa should have global scientific impact. The work that we do should be published in Lancet and Lancet Oncology, and it should have impact on the clinical, the public health setting worldwide. It should have an impact on our scientific thinking in Boston as well as it is in Africa, but that knowledge has to impact the health of the local population. And that's something that happens everywhere, but particularly in Africa, the scientific piece must link to the local impact piece. So with that, if I had 6 more hours, I could go into more detail, but I appreciate your attention. Thank you.